Uh, Good evening, everyone. Dear Pure Urology viewers, I wish all of you a very happy New Year 2025. This is the first day of 2025, January 1st. Today, we have chosen topic on Uroflowmetry, not what we see as a graph, not what we see interpret as the result of the print, but know in detail. That's why I get it. Everybody will have some idea that how the patient voids and how to interpret grossly. But let us not go in grossly, go into the detail and know from Dr. Mayank Mohan Agarwal, today our speaker. In fact, close friend of mine and contemporary of me at PGI Chandigarh, way back 2002 to 2005. So during that period, he was focusing on, all of you know who are in India, focusing on Uroflowmetry and urodynamics. That is the time PGI Chandigarh has acquired new urodynamic mission. Since then, his interest pursued, even though he did interest in other this thing, to my knowledge, his heart goes close to the dynamics of the voiding. So with this introduction, I will introduce him officially and then give the program to Dr. Mayank. So Dr. Mayank Mayank Mohan Agarwal is talking on Uroflowmetry know in detail. Dr. Mayank did PGI Chandigarh 10 years, and then he went to Abu Dhabi. During PGI Chandigarh, he traveled across and written around 50 to 60 international papers. After that, he moved to Abu Dhabi and worked 4 years, during which time he was focusing on endourology, particularly RIRS, all aspects of laser of that time. And then he moved to the private practice. Presently, he is in Lucknow for last years, around 6 to 7 years. And presently, he is working in Apollo Medics as the consultant in Lucknow. So Dr. Mayank Mohan Agarwal completed MCH from Postgraduate Institute, PGI. In addition, he holds National Gold Medal for Urology Award by National Board of Examination, that is Dr. NB. On awarded fellowships, he visited and worked with stalwarts in Memorial Sloan Kettering Cancer Center, New York, University of California, Los Angeles, and Wake Forest University, Winston-Salem, North Carolina, USA during 2009 to 2010. During his tenure as assistant and associate professor in PGMER, he authorized over 85 research articles in international peer-reviewed journals, chapters in urology books. He is an editorial association with BMC Urology and Current Bladder Dysfunction Reports, and has been awarded top reviewer for Gold Journal 2016. He has been invited by several national and international societies for delivering lectures. He has 22 years of extensive clinical experience in advanced urological laparoscopy, uro-oncology, female urology. At the moment, he is also into kidney transplant because his institute is doing kidney transplant, and he also worked with experienced surgeons in the kidney transplant. So he acquired that skill in the last 10 years. And he is doing all endoscopic urology, which I know very well. With this introduction, I will hand over the program. Previously, Mayank has done on urodynamic study basics. Today, we are doing uroflowmetry in detail. Mayank, over to you. Thank you once again for accepting very short notice invitation.
Yeah, thank you, Dr. Chandmohan. Am I audible?
Yes.
Yeah, it's we always talk about your pure program. We have also 4 DNB residents. Everyone knows you, like everyone, and for good reasons, because you've done a lot for development of urology on academic level, not only practice level.
Thank you.
So I will just talk about uro as a stethoscope of a urologist. So it is not unknown to any urologist that if you have come to urology clinic, then even for patients, they know okay, we have to come with a full bladder. Maybe the doctor will do an ultrasound, maybe ask for a uroflowmetry. Even patients know it. But how to go about advanced interpretation? See, Qmax everyone talks about, but urology is much beyond Qmax. So that is what I'm going to unfold in this presentation. So it is a relatively simple and inexpensive tool, and many Indian manufacturers are selling it for even as low as 40,000 rupees. It is basically graphing of flow rate over time in real time. That is all. How it is measured is it done by different methods. So what is uroflowmetry? Uroflow is basically the outcome of relation between bladder function and outlet. Whatever comes out is uroflowmetry. It does not tell you whether it is obstruction, because of bladder dysfunction, or both. It just tells you what is the final interaction between bladder and outlet function. If we talk about one single thing which determines the Euroflow quality is the preload. Like for the preload of volume bladder is the basic driver of flow rate. Social inhibition, obstructions, bladder dysfunction play a lot of, and this needs to be taken care of whenever you are planning to set up a Euroflowmetry. A Uroflowmetry, when a lot of patients, they're in a hurry, there is a lot of noise in the background, too much light, and all these things, they affect the performance of Uroflowmetry by a patient. It is not uncommon that the patient symptoms are not correlating with the Uroflowmetry, and if you go into details, you will find that the patient actually did not pass urine as he or she is habituated to, because of XYZ reasons. So privacy, familiarity, and voiding position. These are three important things which we should take care when we are setting up and performing uroflowmetry. So patient must be counseled before uroflowmetry. Obviously, the doctor doesn't do Uroflow. It's either a technician or somebody assigned and trained for it. So we should always tell the person doing it to to counsel the patient properly. Like, don't drink too much of water. Don't hold urine for such a long time that you're developing pain or severe urgency. All these things, pass urine in natural voiding position. So we should actually, for patients coming from rural background who are not habituated for voiding in sitting in commode, we should have a provision for voiding in squatting position also, particularly for women from rural background. So all these things must be taken care of. Patient should have a comfortably full bladder. A custom position should be told to the patient prior. It could be a squatting position, as I tell. So uh, we should so the patient that do not try flow. It is not some test, like you don't have to pass any exam in while doing this Euroflow. So be just casual, as if you would have voided in a toilet. Careful not to spill the urine out, because it happens many times. Elderly patient, you're trying to make the person sit on in the chair, and then or even if they're standing, they're not able to themselves properly. The flow meter machine is hit, some urine is spilling out. All these things are common, so we should minimize as much as possible. So ask the patient not to strain to get a, unless the patient is habituated that they only by strain thing, but you should not encourage to patient to strain for urination. They should not do any cruising. I will talk more about it. Or play around with the urine stream. It happens many times in the young people, children, teenagers. They would like to just play around with this urine stream. No squeeze and start. Many times it's a common habit, not an uncommon habit of BPH patients, that because their flow is slow, so what they try to do is they will urethra first by pinching the glands and then suddenly release to have a false sensation of a reasonable flow. So all these things to be avoided. Always the technician or the nurse should ask the patient whether it was a usual urination representative of their usual void, or if it is not, then if possible, please repeat it. Now there are more and more, I mean, more four types of transducers available, which actually capture that act of urination. Now even more types are coming up. Even we are working on one Uroflowmeter, which may not need a device, just a computer vision based this thing. So most commonly available is a gravimetric, that is weight transducer. The at what rate they flow, filling up with urine. So that weight is that rate of is considered into converted to a graph. The second most common type is rotating disc. A disc is rotating beneath, and the required to keep the disc rotating at the same speed is the amount of urine, and that is depicted in a graph. Then electrostatic method, as the urine increases in volume, the impedance changes, and that is depicted as a graph. It is commonly used because the dipstick soiled again and again, and it is not a good thing. And fourth is magnetic. I have not come across this optical device. So these are the two common methods by the Uroflowmetry is done. Both have been well calibrated, well researched. Both are approved by National Content Society. If you can catch out of any of these, it's fine. Talk about some interesting flow meters. So, home Uroflowmetry. Let's say you don't have hi-fi device, but you want to know whether the patient is able to void decently or not. So patient can simply tell about just tell about how far the stream is going. On this left side, you can see this U flow meter device. It has a graduated thinning of the funnel, and while the person is passing urine, if the urine is able to hold up in the top one, so it shows that the Qmax is at least more than 15 ml per second. Similarly, spell device, which has multiple side holes and one exit, and higher the point at which the urine comes out hole, it tells you about how higher the flow rate is. So it's kind of overflowing. Now, these are the modern home flow meters which work on various either on a weight transducer, or in this case, it is based on computer vision. So when the flow is passing through a laser, and that will detect how much is the flow rate. These are the newer things, because now the AI is coming to a lot of to a lot in our clinical practice. However, these are not available in India because these are all said and done expensive things. And as an Indian, we don't. We can't afford this much, and actually, we don't need that much of accuracy of flow on a routine basis. So this IU flow has an app, and every time the person pees go through this device, so it will measure the flow rates, it will measure the total volumes, and one can actually maintain even the bladder diary. There are flow devices which have been used, like Min device or IP well device or Urogeny. Other things, these are so many things, but there's no point going to too much details. These are available and may not be as important for clinical practice. Although in doubtful situations, these work because these surpass the social inhibition which happens in the office. Don't have to, wait and get irritated. You are in your home environment and doing as per your own will. So they do have some advantage. Then new things coming up like sono Uroflowmetry. So you would remember our teachers would say, "Ki, bhaiya, let's see what is the sound flow." So that will tell you how good it happens many times. So this has been converted to a scientific thing. Like you can see on the right side in this particular study, they use these three mobile cameras to record the sound at a very high sensitivity level. And this graph was converted to this sound energy graph. And they found that these on the left side, these are the standard flow rates done by weight transducer flow meter and corresponding sound waves. The sound energy curves were corroborating very significantly to the actual measurement, standardized measurement devices. So these are also coming up, and many studies have shown that it is equivalent, reasonably equivalent, and it can be used as a good device. But there is no standardized thing available. See, the useful thing would be that you don't need anything. You can go into your toilet, just record the sound, upload in the app, and that app will give you the details. So it is possible. Now coming to office uroflowmetry. In office uroflowmetry, International Continence Society has laid down some guidelines about the machine which you should buy. Uh, uh, it should be able to measure Uroflow from 0 to 50 ml per second at least. It should be able to measure volume up to 1000 ml. The time constant should be less than 1 second, and it should be able to measure at the accuracy of 5% or better. Means if the flow is 20, if it's showing 20, up to 21 actual flow is acceptable. So most of the imported machines, whatever company you take, the criteria which are certified. Even many Indian companies follow these guidelines. This is one particular company. I will not like to name it. On their web, very well, very clearly written their ICS laid down guidelines that their machine is in fact more accurate, up to 2% accuracy is showing. So that's very nice. So you can take any of these machines for your use. Where we should obviously try to set up in toilet or toilet-like settings. These are the images from my last three places of work where to set up in a toilet-like situation. That on the left side, it's in Abu Dhabi, where we had that rotating desk method, and on the right too, these are weight transducer. And I personally found that weight transducer is a pretty decent method of this thing. I mean, Bluetooth devices are available. Even in Indian machines, Bluetooth wireless connections are available. So you don't have to get into the mess of wires while setting up in a toilet. Now coming to the how the Uroflow goes to the next level. See, Uroflowmetry with the electromyography. Pelvic function is such a common thing which happens to not only children but young adults, and we have seen patients up to 60 years of age have a dysfunctional voiding, that is pelvic floor dysfunction, and how to diagnose them without a urodynamics. Especially in children, it is very difficult to convince a parent, or if you would not like to put artificial catheters in a child and create such a artificial environment to find out a condition like pelvic floor dysfunction, which is very common. So it's very easy to do that. You apply surface EMG like shown in this image and attach to your urodynamic machine. Even Indian machines are now coming up with EMG. So these particular is from our urodynamic machine, which is from MMT, Czech Republic. So you can just apply this EMG and then ask the person to do Uroflow. So you can see this example on the left and right. On the left side, you have this intermittency. On the right graph, you have what is called a staccato pattern, like there are multiple spikes, but not leading to zero. I will come in details. So just see that doing this EMG has made so much of difference. You do dynamics now for making this diagnosis. Clearly, while doing EMG, you can see that as the EMG is peaking, the flow is reducing, and during the period of relaxation, the person is able to urinate. Similarly, this EMG is inversely proportional to the flow rates in a particular situation. So if you can have this, then obviously invasive urodynamics need is reduced. Now, coming to how to, what are the important parameters for uh, Uroflowmetry when we are trying to interpret. So this is an ideal Uroflow bell-shaped graph, and you would like to know UQmax. Obviously, everyone wants to know Qmax, and everyone wants to say that Qmax is more than 50, very happy, less than happy. So I'm going to dissect that. That is that sufficient or it is not. So we would like to know the Qmax, the average flow rate, that is Q average, the voided volume, and the post voiders. These are the four most important things you want to know from a Uroflowmetry. Now, time taken, total voided, total time, voiding time, flow time, all these things, these machines give automatically. You can actually see these. But if you have to have maximum interpretation from Uroflowmetry, Qmax, Q average, voided volume, post void. These four things will give you a lot of almost always whatever you required from a Uroflowmetry. but you have to be mindful. Now, you see that you can actually predict that if a person has a in this kind of flow, if a person has X amount of Qmax, then how much would the average flow be? In general, in this kind of graph, the average flow, which means total volume voided divided by the flow time, would be around 60% of the Qmax. Now, look in this graph. In this graph, if you are given only the maximum flow rate, you will see that the flow rate is about 8 or 9. However, just see the quality of this void. It's such a poor void. What would the average void be in this case? So how to calculate? So you have two time parameters. One is voiding time. That means starting from first drop, first measurable flow rate, the last measurable flow at the end of the void called voiding time. But you can see in this graph, there are multiple intermittent times the flow has stopped. So whenever you are calculating the average, the mileage of a car, so you are measuring only when the engine is on, when the flow is, when the car is moving. Similarly, in urination, you will see you have to check only the times. You have to minus the interruptions. So the average flow means voided volume divided by flow time. Always remember that. Many machines erroneously give voided volume divided by voiding time as the average flow. That is not the correct. As per International Continental Society and as per the logic, it is the flow time as a denominator, which is used for, I mean, denominator, whatever comes, either numerator, I don't know. So that should be taken as this thing. If your machine is giving based on voiding time, you can manually correct it. Now let's talk about the patterns. What do they tell you about the possible pathology? So let's say we say bell pattern, a nice bell pattern like this on the left side, it is considered to be a normal flow. I will dissect further objectively tell you that this is a normal flow or not. On the right side, you see tower-like flow, like sharp rise and sharp fall after a good amount of flow. This happens in cases like stress incontinence or overactive bladder, in the situations where either the user outlet pressure is very low, the resistance is extremely low, like in SUI, or in extremely strong contractions of the detuser. Both these situations, you will find that the average to Q average to Q max ratio will be around 60%. So whenever you have this bell-like graph, either very sharp bell-like or a regular bell-like, you will see that the average to Q max ratio would be around 60%. Similarly, in this kind of situations, you have a bell-like pattern here, but it is basically flattening out. So there is some sort of an either obstruction or diffuser dysfunction. In these cases also, because the shape is bell-like, the average to Qmax ratio will be around 0.6. Now comes to a very typical pattern. Everyone knows a typical pattern, that is box pattern or plateau pattern, in which whenever you find this pattern in whatever age group, in whatever patient, you will always suspect stricture as a diagnosis. In these, you will have Q average to Q max ratio is more than 0.7. It may, the more perfect box pattern it is, more closer to 1 this ratio would. Now, why am I emphasizing ratios? I will just let me finish the next slide and then I will tell you. Then comes patterns like staccato. Staccato pattern is that upper one in which you have the graph going up and down again and again. However, it doesn't touch zero. So in general, whenever the fall in flow rate in between is more than under root of Q max is called staccato, but that's too common. Simply remember a irregular kind of flow in which the flow doesn't reach zero. It's called staccato pattern, like Haklana. Intermittent, very clearly, when the flow reaches zero in between, it is called intermittent. In these situations, the average to Qmax ratio will be less than half. It can reach very low also, 1.2, depending on how much intermittency is there and how much actually the flow happened what in continuous flow and the rest went into intermittency. Now, the importance of to Q average ratio, suppose you don't have a graph, you have only value. Just by looking at values, this ratio, you can imagine that yeah, if this ratio is very low, that means if you had a Qmax of 12 but a Q average of 3, you can say that possibly this guy had a intermittent flow. So you can actually think about, or if the person had Qmax, let's say Qmax is 10 and Q average is 9. So you can always think that possibly this person has um, uh, a box-like pattern, even without having the pattern per se with you. Now, in a continuous flow, general average is omitted by many people because you have a and you know the Qmax. Lot of information is available Qmax only, but there are situations where Q average knowing is important. Like in these two situations, in first situation, your Qmax is around 15. The second situation is Qmax is around 12. However, you can see the average is very low. The average is about 20-25% of the total flow. So in this graph, if you were to interpret the quality of the Qmax will be a suboptimal parameter because the Qmax is not representing the whole flow. Qmax is only just one point and most of the flow is bad. So in this case, Q average will be important. Then always make an attempt, always in all cases, make an attempt to find out the post void residue. Without, in my practice, post without knowing post void residue, you are not, your flowmetry is not complete. Many times, if you are not get able to get a Uroflow, try to get a post void residue done because post void residue differentiates your two major conditions importantly, particularly in elderly people, constipated, they present with urgency frequency, but actually when you find that the post void is women who have prolapse, elderly, not able to come, you can just on if even if you are having an online consultation, just ask for a post void residue. Most commonly is done by ultrasound. In ultrasound, you have even proprietary bladder scanner now in Indian companies like Advent are have or maybe other companies would also have bladder scanners which have auto calculation, and they are available at prices of like 2 to 3 lakhs rupees. Or if you have a standard ultrasound machine, you have three dimensions to like in all the dimension X, Y, and Z scale, and then multiply them by zero anything parameter between zero point 0.5 to zero point 0.7, depending on whether it is more spherical, the close to sphere the shape is, you will the this correction parameter. So 5 or 0.55 you will calculate. But in on an average, the bladder is more of a prism shape. So in when you take these three parameters combined, you give on an average 0.7 as a correction parameter. Obviously, catheterization is the most accurate, but most of the time it should not be done because it's invasive and discomforting, and complications can come out of it. Now, as I was saying, you have a bell-shaped pattern, nice pattern, and but you find that the flow is only 14. So will you call it a normal flow or not? So you will study. They talk about the Qmax is more than normal, less than 15 it is abnormal. I don't think in 2024 or with so many years of understand the flow dynamics, we should talk about Qmax as a parameter for deciding whether the flow is normal or not. Now, why? So you tell me, what is a normal weight? Is it 60 or is it 80 kgs or 100 kgs? So can you tell just by knowing a weight of a person that whether it is normal or not? Obviously not, because you need to know the person's height, because we know that the person's weight is a parameter of height. If the 60 kgs is a weight of a person of 6 feet, it might be actually underweight. And if it is that of a person of 4 feet, it is an overweight. So that means, so what is the parameter we look for? We look for body mass index, BMI. So in all these three situations, For a 165 centimeter person, BMI is 22. Similarly, 80 is also normal for a person who is 6 feet 3 inches tall. 100 is a normal weight for a person who is about 7 feet tall. And 7 feet is obviously not a theoretical parameter. You have these NBA basketball players, many of which reach up to 7 feet. In contrast, if a 60 kg is of a person of 6 feet tall, then BMI is actually low. The patient is gross underweight. Or 100 kgs of a person of 165 centimeters, 5 feet 5 tall. It's grossly overweight. Similarly, similarly, flow is also a parameter of bladder volume. So as the BMI, which is a height and weight index, similarly, the flow should always be considered in relation to the bladder volume. Now, what is that parameter? Similar to I. We called it VQI. We published it in Urology Urodynamics. It was based on over 600 to 700 measures of healthy adult men and women, and they were also checked against uh, around 300 to 400 abnormal parameters, the patient who was symptomatic for voiding dysfunction. So we found that bladder volume adjusted flow rate index, it's called VQI. You can also call it corrected Q. It is basically Q, that is flow rate, whether average or Qmax, divided by bladder volume, that is voided volume plus post void residue. Or if you don't have a PVR, even voided volume is good enough. So we found that
Mayank,
in men and women, these
Mayank,
values are as per written here.
Mayank,
In general, if you have a VQI max of more than 1 in either man or a woman, or VQI average more than 0.6, that is 60% of the Q max, it is considered to be acceptable flow. So just changing it into some practical parameters. For a 300 ml void, a Q max of 18 plus is acceptable because this VQI max is around 1. And Q average of more than 10 is good enough because it's the VQI average is 0.6. However, the ideal value would be more than 22 and 14. At 400, this value will be 20 and 26 respectively, not 15. If a person has voided 400 ml and the Qmax is 15, you don't call it normal because the preload is too high for a normal flow. So 15 would be actually low in this case. Another way of looking at it, this flow and volume relations, one is by formula, another is by nomograms. Now, all the machines, even Indian machines, it's really, I mean, I don't know what to say. I've tried so many times with so many people. These machines are looking at graphs which are from Caucasian population. Cherokee nomogram, Liverpool nomogram, we have proven beyond doubt that these nomograms are not applicable for Indian men and women. And we at PGI we did these studies. All are well recognized and published in urology, urodynamics. These are the nomograms created for Indian people. And we found that these are nomogram, which actually are about 2 standard deviation below the Caucasian population, are applicable to Indian men and women. Despite getting published in a journal which is by International Continence Society, have not be recognized beyond 1 or 2 sentences in papers. But still, as a clinician, we should go to the next level. That we should consider these nomograms. And if we see nomogram, finding a nomogram is not difficult, but it may be cumbersome. You may just simply do this mental maths of under root of voided volume. Just see whether it is Qmax or not. If it is less than Qmax, then your flow is pretty good. The value does not matter. The Qmax value does not matter. It has to always be looked into in relation to volume. Thing I want to know, I want to tell you that this graph is from a very old edition of Abram's Urodynamics book from 2006. He did this Uroflowmetry of one person at different voided volumes. And many studies after that also have proven that the cutoff point of ideal bladder behavior is at around 500, 450, 400 to 500 ml. As the flow rate, as the bladder volume goes beyond that, actually the flow rate reduces because the bladder muscles are overstretched, and that overstretch leads to less contraction of the muscles. So, if we have a flow volume around 150 to 500, that's the ideal kind of volume we're looking at for the most interpretable uroflowmetry. Now, coming to the last part, artifacts. So, artifacts can happen due to lack of privacy. The patients often may say that it was too noisy. There was somebody behind me, and very, so I could not do it properly. The voiding position, it the patient, you should always ask the patient which position would you like to void, will be the most comfortable for you. Then this is the cruising artifact I was talking about. The If the person is moving around too much, trying to move around too much the flow, so this is how you are going to get the flow graph. So this is the ideal place. Somewhere on the wall of the funnel, the person should ask to urinate, not even in the directly, because that will create a one artifact of sudden jerk, as you can see in this right side graph. Then there can be a kicking artifact that while passing urine, if the flow meter is kicked, so there will be a sudden high peak, which most of the modern machines are able to filter. However, many machines do not, though you have to do a manual filtering. So this is the squeeze and release artifact. The person is trying to hold urine, squeeze it into urine, release suddenly. So to have a artificially created high flows. So to conclude, setup of is quite basic. However, its validity lies in how the studies perform. So, right from where you set up your machine, how you create environment in your urine flow, how to get optimal bladder volume to get a accustomed outflow, and how do you interpret actually lies. You can do a lot more flowmetry just beyond Qmax. So Qmax should always be seen along with Q average, voided volume, and preferably with immediately done PVR. If not possible, then at least have an ultrasound report in which some PVR is mentioned. Habituate, this is the time to habituate yourself to do maths of under root bladder volume, or if the PVR is not available, under root of voided volume to know how good is the flow. That means Qmax divided by bladder volume or under root bladder volume, if it is more than 1, reasonable flow, above -2 standard deviation of normal. Similarly, Q average is more than 0.6, you will say that it is an acceptable flow, even without having hi-fi things like graphs or the nomograms. So, like, we have totally given up using weight as a obesity parameter. We always go for BMI, although it is also not perfect. So, I'm also saying that knowing that VQI is a perfect thing, but it is certainly better than knowing Qmax. We have already proven it, and there is a logic behind it. It is not appropriate to evaluate Indian Euroflows on Syracuse Liverpool nomogram. That also has been proven beyond doubt. And I'll encourage more and more urologists, particularly the younger one, to use PGI nomograms, or at least test the PGI nomograms and Syracuse nomograms to get convinced about, or maybe refute that theory. So mindful use of this simple tool can take your insight into patients' LUTs to the next level. And many times you can actually do without urodynamics, I mean invasive urodynamics, when you are looking at patients' LUTs. So thank you very much. And I want to conclude by saying that in 2025, let us take a pledge not to use antibiotics by habit, reduce antibiotics as much as possible, because the ESBL carbapenem resistant organisms, they are on the prowl, and we don't have much again. Thank you very much.
Yeah. Thank you, Mayank. I'm audible?
Yeah, very clearly.
Yeah. So, good presentation. I could understand some of the details which I didn't know. The only thing is, can you elaborate the Sirosky nomogram just for the sake of information, going to back to that slide, even though they are not applicable, if you don't mind?
Yeah, yeah.
Two graphs, just for the completion's sake, because
Yeah,
most
yeah,
of
yeah.
our graphs show that. At least you can imagine it's for Caucasians, but it's okay if we know a little bit about that.
Yeah, yeah. Just 1 second.
Yeah, yeah, please.
New share.
Yeah,
Are
yeah,
these visible?
yes, yes.
Yeah. So these graphs are whatever nomograms. So many other nomograms are also available. So these graphs are plotting of Q max against the voided volume or Q average against the voided volume. So um, these are lines. So in this Sirocki nomogram, the top line is the median, the mean flow, normal flow. And similarly, this line is. Can you see my arrow also?
Yeah, 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 yeah.
Yeah, yeah. So this line shows the mean of the arrow also. Anything below two standard is considered abnormal. In this Liverpool nomogram, these lines are made on percentiles. That is also same. These are all statistical concepts of using either standard deviation or percentiles. So anything which is below two standard deviation, which is approximately 95th percentile, 68 and 95 percentile, standard deviation 1 and 2. So if it is below 95 percentile of the graph line, it is considered abnormal. In our study, we found that you can see this red line going along in the Liverpool nomogram.
Yeah.
These are the means of Indian normal people, adults.
Okay.
Our mean was at 16th percentile, not at 50th percentile, which they should have aligned if this was flow as Caucasian population. So when we when we created our own nomogram, you can see these nomograms, they are showing fall after a certain point. So this fall is at 500 ml volume, which is the peak of voiding efficiency of pumping efficiency. So, but we nevertheless made it up to 1000 or 800 ml of flow to incorporate more number of voids. Suppose a person has voided 700 ml. Why do you test it? Because in these nomograms are not beyond 500 or 600 ml. So these nomograms are up to 800 and 1000 ml. So to incorporate more these things. So in our graph, the central graph, the central line is the median line. The
Okay.
green lines are within one standard deviation lines. The red lines are within deviation standard lines. So anything below the red line is certainly abnormal. Anything below the green line is somewhat abnormal, but may lie in the normal range, normal outlier range, like that.
Okay. So now let's ask the questions. So normally, Mayank, can we close this?
Yeah.
If somebody has more post-void residual urine continuously for 4-5 visits with reasonably good flow, if average flow also reasonably good, how
Yeah.
do you, does it become a suspicion for urodynamic study, or still you can help out yourself that around 150 above PVR is there always, and nothing. He says that I have frequency urgency. These are the common clinical scenario I am saying.
Yeah.
It's not really obstructive pattern, not very bothersome symptoms of obstruction. So how do you interfere uroflowmetry then?
Yeah. So basically, for interpretation of Uroflowmetry, post-void has a very important role. And as I said, if you just do, if you do the interpretation of, let's say, even VQI max just based on voided volume. So let's say in your case, you're saying, let's value for, let's say, Q max of 14, 13, 14.
Yeah, 14.
Okay. So
Around
let's say
350
Qmax.
ml, he will void 300 ml.
So 300 ml the person is voided, and the Qmax is, let's say, about 14. So your corrected Qmax will come at about 300, 118, around zero point 0.7 or something.
Okay.
But if you add the PVR in it, so your corrected flow actually has gone down further. So your corrected flow has become maybe zero point 0.5 or less.
Yeah, yeah,
So
yeah.
that means that this value is representing the person's flow quality up to a better extent. Now, whether to do anything or not, that depends on many parameters. As you would know that elevated post-void residue may not be problematic as such if the person is minimally symptomatic. But minimally symptomatic means not a neurogenic bladder patient, not a patient who has altered sensations anyway. In a situation where there is no hydrolysis, when in a situation where there is no evidence of UTI, so in those situations, keep that thing under follow up. And urodynamics is required generally only before any intervention. So if the person says, no, doc, I'm okay with the medicines and I'm not feeling bad enough to undergo any surgery, and your flow rate and your post void, even if it's high, it says that no hydronephrosis, there is no UTI or this thing, so you don't have to do anything about it.
One good question by Dr. Nikhil, as you are mentioning repeatedly that Caucasian population PGA, Caucasian population PGA. Can you talk to the Indian Uroflowmetry mission companies to keep Indian population data into those graphs? At least people will quickly conclude which line it is falling. Are you trying anything because you have done some amount of
See,
research?
I have tried. I mean, you can say my only success so far has been my incorporation of this concept in the Uroflowmetry document of the International Continence Society, published in Continent just very recently, 4 months back.
Yeah,
That is all I could get. That one paragraph, which is saying ki this doctor has tried to decipher that in Caucasian population it may not work, and they are separate this thing. Okay,
okay.
I have. You can say that I'm hell bent. I did not try to call them up personally, but I have mailed, and when I was in PGI, and soon after that, I tried to talk to them. Everyone says yes, yes, we will do it, but nobody does that. And I've been a lazy person. I must say I'm a lazy person, but I mean, with more free time, I'm determined to get it. And in
Yeah,
fact, I'm working on. I mean, I've just conceptualized a new Euroflowmeter which won't need any machine, along with my children who are in IIT now.
yeah, yeah, yeah. Very good. Uh, Wireless Bluetooth, do you have any experience? Are they reliable?
Yeah, yeah. So we have been using wireless, you can say, for last 6 years, ever since in Lucknow. So we have wireless uroflowmetry machine. They're reliable, but the only problem is that if you don't take care of them, so once it happened in Medanta, and once it has happened in my new hospital in Apollo, that if you're not taking care properly, the water goes inside the machine and that connection gets damaged, number one. And because these are battery based device, so you have to be mindful that when you're connecting, that Bluetooth connection has been successfully achieved and you don't have a low battery. If you
Okay.
can manage, because sometimes it has happened that during the study that suddenly the machine stopped transmitting the data because the battery went down. But otherwise these are good, actually. It's a good thing. You don't have to have a mess of wires.
Some of the patients says that they asked me to take the fluid faster and I went in, I did not get it. They have got the PVR done, PVR high, urine flow, average flow, everything is low. And after that I went, I nicely passed, there was no problem, doctor.
Yeah.
So in such patient,
Yeah.
what do you advise?
So I will
Yeah, I
say
have
that
completely
we
passed.
have,
If you want, you check again. His
uh,
language says that he passed very well afterwards.
yeah. So there are both sides of the story. Many times when the patient comes to office, they are seeking that the doctor will say that nothing is required. You just take the medicine and go. However, I've seen both the things. It happens both ways, that there was too much of rush in the uroflowmetry room and there were so many people around and the flow was not good. The patient was anxious. and actually he or she passed urine properly in the toilet. So the minimum we can do is, if the post void was high, we'll just say, ki, okay, when you feel the next time, please go and pass urine in the toilet, and then we will just check the post void. If there is a lot of discrepancy in that post void, then of course we need to repeat the test and not take action based on our Uroflow.
Okay. Uh, in case voiding volume is always less,
Hmm.
150 ml every time, whenever he drinks, also he passes 150 ml, whatever he drinks, and probably the pattern is 150 ml voiding, 150 ml. Post-void
Your
residual
net
is
connection
not,
is gone. Hello.
hello. Post-void residual is not that much.
Yeah, yeah. Sorry, you have to repeat it. Your net
The
connection was
voided
gone.
volume is less.
Hmm.
Interpretation of uroflowmetry becomes difficult, or it's okay. 150 ml, I mean to say.
So anything, matlab, I generally feel that anything more than 100 ml, if the flow is explaining the patient's symptoms, then I will accept it. Because if the person is not able to hold more than 150, so either this person has a small capacity bladder for whatever reason, or a severe overactivity because of which it's not able to hold. So you cannot keep on beating around the bush and come again like that.
Yeah. So there's some problem related.
Yeah.
Okay. So thank you very much, Mayank, and I
Thank you.
appreciate. And this is a common subject where most of the urologists do it in their offices. So I thought it will be very useful for the many of them have
Thank
commented,
you.
and nearly 150, 170 people have attended on the new year, and I'm happy that we have chosen a good topic and speaker. Thank you once again for that.
Thank you. Thank you, Janmo. Thank you.